Should HIV practitioners screen all treatment-naive patients who are initiating antiretroviral therapy for HIV-associated neurocognitive deficits?
There's a difference of opinion about that. So studies have shown that about 40 to 60% of people with HIV have cognitive impairment. And that prevalence of impairment supports the idea that screening is important. But inherent in any question about screening or diagnostic tests is cost effectiveness. And so the screening test has to be sensitive and specific, and it has to lead to a change in the management of that patient. And so on the one hand, in one perspective, the screening procedure not only helps diagnose HIV-associated neurocognitive impairment, but it helps diagnose cognitive problems due to other diseases like substance abuse disorders and mood disorders and neurodegenerative diseases. And so there's value in identifying whether that's happening, and it can alter the management of that patient. On the other hand, people have argued that the majority of people with HIV-associated neurocognitive disorder have something called asymptomatic neurocognitive impairment. And until recently, there have not been much data showing that asymptomatic neurocognitive impairment results in important clinical impairment, so changes in people's lives. By definition, asymptomatic neurocognitive impairment not only has no symptoms, but it has no functional impact, no day-to-day impact on people's lives. So the counter-argument is, why screen for something that has no impact on daily functioning? So what we have found recently in one of our large studies is that even a diagnosis of ANI, asymptomatic neurocognitive impairment, increases the risk for subsequent progression to worse forms of neurocognitive impairment. So that really supports the idea that there is value in looking for it. And in the Mind Exchange recommendations that we published last year with 65 other experts, we recommended that all patients be screened for neurocognitive disorders, at least symptoms, which is very simple to do, and at least with a brief screening instrument, so it wouldn't require much clinical time. However, on the other side of that, very recently, this year in 2014, a group from London published an opinion piece suggesting that there should not be universal screening for neurocognitive disorders. So there's a difference of opinions. And in part, it gets back to this idea that there's not strong evidence about how to manage neurocognitive disorders once they're found in HIV. And as was discussed in the lecture today, there is a variation in the findings from study to study to study in the relationship between certain drugs and neurocognitive impairment. But many of these are attributable to two issues. One, suboptimal methods. So many of the studies that have not found an association did not have high-quality methods or were cross-sectional in design. And two, low power. Many of the studies that did not find an association had small sample sizes or did not follow people for a very long period of time. And so the studies that had higher quality methods and that were longitudinal and followed people for longer periods of time were more likely to find associations. So we think that there is an association between what antiretroviral someone uses and their neurocognitive functioning, and that argues or supports the idea that screening is important.